All right, well, we are at a couple of minutes past the hour, so let's jump in. Firstly, a very warm welcome to the next in this sequence of ICODA Grand Challenges webinars, and thank you for spending the time with us today. We've covered a number of topics in these webinars so far in the series, from some of the individual driver projects to topics such as natural language processing. All of the replays of the sessions are available from ICODA's website, so do take a moment or two to go and have a look through some of those. Would be excellent. Today we are going to cover privacy enhancing technologies with a specific focus on trusted research environments. So privacy enhancing technologies, or PETs, as they are more affectionately known. I'm privileged to be joined today by Joseph Ouma, who's the senior programmer in one of the ICODA projects, the periCOVID study, and also Dr. Carl Marincowitz from the PRIEST study. So they join us from the Makarere Johns Hopkins University in Uganda and Sheffield University here in the UK. So delighted to have them with us, and I'll take you through the agenda in a moment. Just a couple of bits of housekeeping as well. Today's session is being recorded, so just be aware. And also please put any questions that you have for myself or the other presenters in the Q&A section for the webinar rather than the chat. Okay, hopefully that makes sense. Let's jump in. So the agenda for today is a bit of an overview of privacy enhancing technologies, trusted research environments, a bit of background on the International COVID-19 Data Alliance, ICODA, for which I'm technical director. And then the far more interesting and exciting piece of the webinar will kick off when Joseph and Carl will take you through an overview of their research projects and their experiences using trusted research environments within those projects. So we'll each aim to do about 15 minutes. As I say, please put questions in the Q&A box as we go along, and we'll save some time for those at the end. So let's make a start with privacy enhancing technologies. So I think firstly, important to understand, what do we mean by privacy enhancing technologies? What kind of thing are we talking about here? And these are technologies really aimed at enabling data protection and minimizing use of personal data. So this is all about protecting both your personal data, my personal data, and anybody else who's part of a cohort. And this is especially key in health data research, to protect our privacy as patients or as part of those cohorts. And traditionally, I think if you look at the top couple of boxes, the first thing that we think about with privacy enhancing technologies in a traditional sense is encryption. So encrypt the data, so if somebody inadvertently gets it, they can't access it and read it. Or de-identification, so removing identifiable information from data. So that might be things like your name, your date of birth, a localized address, something like that, and replacing it with some kind of ID or token. So you still have the data, but you don't know who that data belongs to. We have a new set of what we call emerging privacy enhancing technologies, of which trusted research environments that we're going to talk to today are an example of. But we also have some other things that are gradually coming to the fore. So federated analysis, where the data doesn't move. So data would remain in a single repository and researchers would send access requests to that data and results would be returned. Differential privacy, so that's where algorithms actually don't know if particular individuals are in result sets, so very difficult to ascertain or identify an individual using differential privacy. Things like homomorphic encryption, where analysis is actually run on encrypted data, and synthetic data, where data is artificially generated based on algorithms and models. So there's no silver bullet here in terms of data protection. This is really a continuum. And I think it's important to understand, the more that we obfuscate things and the more we make things completely unidentifiable, often the less useful that data is from a research perspective in terms of actually answering a specific question. But I think the important thing to understand is this is a continuum, and quite often a blend of these privacy enhancing technologies is able to achieve a good balance of both research usefulness and protecting the individual. So you'll hear trusted research environments, which we're going to focus on today, referred to by other things as well. So, we use the trusted research environments, TRE is the typical acronym. You'll hear virtual research environments, digital research environments, secure research environments, secure data environments. It's all effectively the same concept under slightly different names. So what do we mean by a trusted research environment, and what are some of the characteristics? So typically a trusted research environment provides a set of things like an airlocked environment. So any user accessing a trusted research environment is authenticated, often pre-authenticated, and their researcher accreditation is assessed before they're even allowed to go towards logon. They're not allowed to take anything out of a trusted research environment without it going through quarantine and making sure there's nothing identifiable in that output. Usually they have a set of configurable tools and services, so tools within which you can do analysis, and typically they can be added as well. And most trusted research environments will allow you to add and configure tools and services. And they're really there so that a research team can work in a secure, collaborative environment on a set of data provisioned into that trusted research environment by a data custodian. So it does save very much the having multiple copies of data with lots and lots of researchers as well. Typically, they're available remotely, quite often with cloud access as well, which has been particularly useful in the International COVID-19 Data Alliance with researchers all over the globe. Very often it's straightforward to add more computing power to a trusted research environment. So if you are needing to do a particular analysis or run particularly intensive algorithms, you can add virtual machines to the environment and very secure data storage. So there's some of the benefits. Just stepping back a little bit and looking at the ICODA initiative. The ICODA initiative was convened midway through 2020, really to convene a rapid response to the COVID-19 pandemic, but leave behind a lasting infrastructure, set of processes and learnings. And as many of our projects, and some of the ones that you're hearing from today as well, are in the wrap-up phase of the initiative, it's important that we capture all of the learnings for that, and you will see more and more publications and outputs from the initiative as we go over the next couple of months. We've tried to do things a little bit differently. We've tried to focus on making sure that data is fair, so findable, accessible, interoperable, reusable, and discoverable in a very open fashion. All of our projects have run within a secure analysis platform, our trusted research environment, the ICODA Workbench, so a privacy enhancing technology. And some of the projects have been using federated analysis as well. So they've actually been sending analysis requests to the data from our trusted research environment to another environment and having the analysis results come back. And we've really focused on trustworthy data stewardship through the initiative. We've used a concept called the 5 safes in the background for the whole project. This is a concept that was brought together by the UK's Office of National Statistics, the ONS, and it focuses on 5 categories. So safe people, making sure that researchers are trained and authorized and have appropriate accreditation to access data. Safe projects, making sure that all projects are approved and are in public benefit. The projects are done within a safe setting, so the trusted research environments we're talking about today. Data is curated safely, so the majority of the ICODA projects have been working with either de-identified or summary level data, so no identifiable personal data within our project set, and all outputs have been screened to ensure that there is no disclosive information in those outputs. So those 5 safes provide a really nice lens within which to review health data research. The ICODA workbench itself, our trusted research environment, is provided by our partner, Iridia Informatics. The workbench is cloud hosted on the Microsoft Azure cloud platform, and the Iridia team have been able to stand the workbench up in multiple different cloud data centers across the world for us as part of the ICODA initiative, which has been fantastic. The workbench provides a secure 2-factor authentication for researchers to log on, a collaborative working space with open tooling, but other tools can be added, and a number of our projects have actually had tools added to their workspaces. You can bring your own code and third-party software tools as well. You can add in compute power, which a number of projects have needed for particularly weighty analyses. You can add in virtual machines in either a Windows or Linux form. And also a set of metadata services has been provided, which as part of the ICODA initiative, we've integrated with our ICODA gateway to make sure that all of the metadata in the project is available in a findable, accessible, interoperable, reusable fashion. So that's where all of our projects have been working. We've had a global portfolio of projects, two of which are with you today, but we've been covering a variety of topics in a variety of locations all around the globe, from things like effectiveness of vaccination in Brazil, all the way along to health service delivery and multi-country consortia looking at how the pandemic has affected health service delivery across multiple countries. So it's been our absolute privilege to be involved with all of these 12 projects all around the world. It's been a fantastic set of researchers, and they've made some really good use of the tools that have been provided as part of the initiative. So I think with that, that's hopefully sets the scene in terms of a little bit about privacy enhancing technologies, a little bit about trusted research environments and some of their characteristics. I'd like to pass the baton over now to firstly Joseph and then Carl to take you through a little bit about their projects and how they've learned and used trusted research environments in practice and some of their lessons learned. So with that, I'm going to stop sharing, and Joseph, I'm going to pass the baton over to you. Joseph? Joseph, you're on mute.
Oh, hi, Neil. Thank you. I'm just trying to get my slide up.
That's all right. Take your time.
Okay.
And please,
see it now.
I was bang on time at 15 minutes. Yes, I can see your slides. Take us away.
Okay, good. Thank you very much, Neil. And good afternoon, good morning to everyone. Thank you.
And Joseph, do you want to turn your camera on? There you go. Perfect.
Yes. Thank you. And just to say it again, good afternoon, good morning, everyone. Thank you all for making time to join the webinar this morning or afternoon, wherever you are. And also thank you for the organizing team for inviting us to share our work and experiences using the ICODA workbench. And like Neil mentioned, I'm Joseph Ouma, the Senior Data Manager and Biostatistician here at MUJHU. So I'm going to be talking to you about our project in Uganda, the incidence and risk factors for COVID-19 among pregnant and lactating women and their infants in Uganda. Just to highlight what I'm going to be talking about, I'll be presenting to our team the goals and objectives of the project, the progress we've made, and any achievements we've had so far, and our experiences using the ICODA workbench. Our team was led by Professor Kirsty Ladro. She was the principal investigator. And we also had the Professor Philip Amusoke, who is the executive director of MUJHU here in Uganda. Myself, and we also had clinical members of the team, Dr. Lorraine Ouma, who was the program manager for periCOVID and part of the ICODA project. Dr. Mary Johire, we had Gordon, who was in charge of our data management, and Alona and Edina, who supported data extraction and cleaning. And we also had Ayub and Rachel, who contributed to our work. In terms of the partnerships and collaborations, our work was led by MRC UVR as the lead institution, MUJHU, which is Makarere University, Johns Hopkins University Research Collaboration, really supported the implementation. Our other partners were Kawempe National Referral Hospital here in Uganda, the Division of Health Information, Ministry of Health here in Uganda, Department of Maternal and Neonatal Child Health here in Uganda, and of course, ICODA, International COVID-19 Data Alliance, supported us with the funds. At the inception of our project, the gap, here we noted that real-time data collection, analysis, and reporting are needed to support changes to guidelines and care. And therefore, we thought that electronic health records provide this platform that's much needed to support this clinical care and disease surveillance. So therefore, our project set out to determine the risk factors for adverse pregnancy and neonatal outcome during the COVID-19 pandemic using the electronic health record data. And specifically, we intended to develop a risk factor model for indirect effects of COVID-19, for the indirect and direct effects of the pandemic on maternal, neonatal, and child health services in Uganda. We also wanted to identify the at-risk populations who would benefit from things like vaccination catch-up programs after the closures or restrictions on the to contain the epidemic or the pandemic. We also intended to formulate guidance on infection prevention and control during pregnancy and the postpartum period. And then lastly, we wanted to develop a means of health COVID-19 dashboard for maternal and neonatal child health data for this and future pandemics. We used data from Kawempe National Referral Hospital, a maternal and neonatal child health facility providing services to more than 30,000 women annually here in Uganda. The hospital uses Uganda, which is an electronic medical record system that captures patient level data. The system is developed based on Ministry of Health Management Information System tools. And in particular, we use antenatal data for the period January 2020 to October 2021 for our study. The specific outcomes for our study was death, maternal death, neonatal death, and infants below 6 months, deaths registered at the institution, prematurity, stillbirths, miscarriage, gestational diabetes, antepartum and postpartum hemorrhage. Other variables that we extracted and included in our data include maternal demographics, such as age, level of education, marital status, and areas of residence. And also, we analyzed data on parity, probability, and gestational age. We also extracted data from the Ministry of Health COVID-19 dashboard, which had information on timelines, the lockdown timelines that were initiated by the government. So in terms of progress and achievements, some of this is that we had stakeholder engagement meetings with the Ministry of Health and Kawempe National Referral Hospital staff. The meetings are particularly intended to get guidance on dashboard development, selection of indicators to be included in the dashboard, but also we wanted to build excitement and acceptability among these key stakeholders and initiate a use case as well as ongoing commitment from this particular group of people, because they were the ones intended to benefit from this dashboard. We also intended to develop the risk factor model, which we did, and we achieved that. The manuscript of this is intended to be submitted for publication by end month, September. We also developed an abstract on data visualization, and this has been approved for poster presentation at the Global Health Network Conference in Cape Town, South Africa, and it's due this November 2022. Just to show you our stakeholders in one of the engagement meetings, on the left there, you can see a dashboard on the screen up being reviewed, and members are giving feedback on what it looks like and how it can be helpful to them. And the same thing on the right, looking at the dashboard hidden from our view here. So this is just the dashboard with a more clearer view. The kind of indicators that will be that's shown on the dashboard. We have information on antenatal, labor and delivery, and specific outcomes. So in particular, for this period, so the dashboard can be customized, can be the user can extract data for a day, a week, a month, or a quarter, and therefore these statistics will represent the period that the user selects. So for example, here there were 2,000, over 2,000 admissions, and then we had 2,159 deliveries. Out of those deliveries, we see that 434 were preterm, whereas term births were 1,726. The same dashboard could show the other outcomes that I just mentioned earlier, and this is what is would help the hospital management, healthcare providers to make prompt decisions about service delivery in the hospital. So in terms of the workbench, onboarding and preparation, our team were really naive about sign-ups. So we had training and signing up for sign-ups, which introduced the team to the environment. The team was showed the available tools to share, how to organize and promote research work and outputs within the environment. We did sign the data processing agreement, and further training on the mandatory ICODA workbench courses and modules. And finally, the team members were accredited and granted access to the study workspace, IROC study workspace on the workbench. One of our experiences, our data in the workbench, is that we had quite a large data set, as you've seen in the dashboard. Particularly for this study, we had extracted over 49,000 antenatal records and over 51,000 labor and delivery records. And this, however, we noted was beyond the workbench data table editor specifications that had 110,000 records. So therefore, a Windows VM was deployed for the workspace, and we had interactive sessions with the workbench team to inform these sessions, particularly helps the team and ourselves to understand the workbench space and utility, and further interactions why use this interaction was also useful for the team to understand the need of the different users of the workbench. Given our huge data sets, the team, and given that we had deployed the Windows VM, the team was able to extract the R Markdown modules, and these were made available in the VM machine. And we also had further interactive sessions where our team was shown how to use the modules for data analysis. Just before our data was uploaded onto the workbench, we had data curation, which was supported by the MMS Holdings, Inc. And just to our right, you can see the kind of data that we are talking about to do curation on. So this curation, because it was a huge data set, the curation was requested to be done outside the workbench. Therefore, we had to sign another data processing agreement with MMS Holdings. And the team also helped us to improve our study metadata. We also got additional support from the statistical expert group, and a lot of further interactive meetings, training with the workbench team helped us to really understand how to use the workbench for our analysis of the MUJHU machine. Benefits that we realized, we thought that the workbench team was very supportive in guiding our team all through the process, uploading our data onto the workspace, using the exported modules, and in resolving any other challenges that we had arising as we were working through the workbench. We noted that our data was in a single space, single secure data space, and only accredited study team members were able to access this data. There was also secure file storage, and sharing for large files was removed, as opposed to other cases where files would be shared among the users. All the members were able to go into the workbench at any one time and be able to do what we had to do within our project. The analytics and tools to model our data were very efficient and available for use whenever we wanted to. While using the VM, we also noted restricted access to external resources such as the web, and this was reassuring in our data security. And also using the airlock provision available in the workbench, the team members could only download datasets after authorization from the workspace administrator. And again, this was really a reassuring in security of our data and how the data could be shared around. We thought that there was improved collaboration among the members, as members were able to contribute directly onto the data analysis code and other inputs as the analysis progressed. Just a bit of challenges, but we think that these were resolved as we went along with the work. So these are not challenges that failed us completely, but were resolved within the period that we're working within the workbench. The R Markdown modules, using them outside the environment, needed us or team members to have some idea of using the R program, which to some was quite new, and that was a bit challenging, but we were able to overcome that. Our data being routine service delivery data, and as you've seen, having a lot of text data fields, working collaboratively with the MMS team, were able to complete the data curation. And also working in the environment required large bandwidth and needing some patience to run and rerun our scripts. Just to acknowledge the team that really worked tirelessly with us, the workbench team and engineers, the statistical expert group, the MMS ICODA data curation partner, Ministry of Health, Kawempe National Referral Hospital, and the study participant whose data was used for this project. Thank you very much.
That's brilliant. Thank you, Joseph. Really interesting and inspiring. Let's, if you could stop sharing, let's pass the baton to Carl, who can take us through how his team have been using the TREs, and then we can open up for questions and Q&A. So Carl, over to you.
See my presentation. So I'm Carl Marincowitz. I'm the principal investigator for the PRIEST in low and middle income studies. And what this was based on is about 2 years ago now in the UK, we had just completed a large cohort study where we collected data on over 40 emergency departments in the UK in order to develop a triage tool which could be used to rapidly and transparently determine if patients with suspected COVID needed inpatient hospital admission from the emergency department based on their risk of subsequent deterioration. Shortly after this, our colleagues and collaborators at the University of Cape Town looked at the literature and found that although there were lots of triage tools being developed in high income settings, that there wasn't really any tools which had been validated or developed in low or middle income settings. And this was a bit of a problem for our colleagues in the Western Cape, as they weren't sure if things like the PRIEST tool were applicable there. So on the basis of this, we developed a collaboration and partnership and applied for the ICODA funding as part of a pilot project. And what we aim to do is essentially develop a PRIEST-like risk stratification clinical tool which can be used to help triage patients with suspected COVID in emergency departments and low and middle income settings, specifically the Western Cape and also Sudan. And key to that is involvement in clinical and patient stakeholders to make sure that the triage tools are acceptable both to patients and clinicians and are also usable. And we also explored the use of machine learning techniques to see if prediction could be improved. So in terms of our team, what we had is researchers at the University of Sheffield who'd been involved in the original pre-study in the UK. And that was the basis kind of for our machine learning and other modeling techniques, and also for triage tool development clinically. And then from the University of Cape Town, we had clinical expertise from people like Professor Wallace, and also an existing collaboration in Sudan. We used 3 quite large cohorts for our study. So the first is from the UK, which is the UK pre-study with around 20,000 patients from the first wave who had presented with suspected COVID, and that had been used to develop the original PRIEST tool. Luckily, in the Western Cape, shortly before the outbreak of COVID, they'd implemented electronic records. So we were able to suck out a huge amount of data on about 450 adults who presented from August 2020 to March 2022 with suspected COVID in the Western Cape. And from Sudan, from an existing collaboration with the University of Cape Town, there was also an ongoing multi-centre cohort study collecting data on patients with suspected cohort presenting to 4 centres in Sudan, mostly the Khartoum region. So what we're aiming to achieve from this, and we've already achieved about half of these objectives, is first to validate existing triage tools which could be used in the emergency department to determine the need for inpatient admission. And that includes the original PRIEST tool, as well as things like News2, which are routinely used in the UK. We've developed a new and modified version of the PRIEST tool using Western Cape data, which is applicable for use in South Africa and other settings which use similar triage methods in the emergency department. And we're also validating the new tool and other existing tools in the Sudanese cohort study. We've also done some machine learning to see if it can improve prediction of adverse outcomes and therefore need for inpatient admission. So in terms of the role that the trusted research environment has played, the main one is for us has been a central secure repository in which we can keep these 3 data sets. Anonymization of all the data sets occurred before they were uploaded to the trusted research environment. However, each cohort and data set has got specific data sharing agreements attached to it, and that means that they have to be processed and used and shared in certain ways. And the trusted research environment has meant that there's a central repository where the international team can access and keep all that data in a secure way. From my perspective as the PI, it's meant that I've had control of those data sets and have ensured that any data flow from the trusted research environment to members of the research team has been in accordance with the data sharing agreements and stipulations of the data controllers. And there are 3 essential data controllers. So one is the University of Sheffield for the UK priest data. For the Western Cape data, it's the Ministry of Health in the Western Cape. And from Sudan, it's the Ministry of Health from Sudan. There are various rules which govern how we can share and access that data. And I've been able to keep an overview as the PI that we're sharing the data in a way which fulfills our data sharing agreements and obligations to the data controllers. In terms of analysis, I mean, the main advantage is that you can access the trusted research environment and the virtual machines which we've been using in theory from anywhere in the world, and that's been pretty convenient for our team. The simple suite of descriptive applications which have been made available on the workbench are pretty good for simple descriptive statistics comparison of the data sets, and it's meant that we've been able to compile comparisons of the different population characteristics relatively easily in order to inform a more complex analysis. For our analysts which use Linux and Python, it's set up for that, and Medina, who's the main analyst working on it, has found it very good for that. And although it's been less of an issue for us, because most of the analysis has been done by the University of Sheffield team, it is a very useful function if you've got analysts based in different parts of the world or not in the same geographical location, as they can all work simultaneously on the data sets and share code and things like that. However, there have been a few issues. So these are, I asked everyone who's part of the analysis team to fill in a quick survey about how they found using the trusted research environment. And this is the kind of feedback which I got back. So one of the things is that you do need large bandwidth to maintain the connection, and that can cut out, and that can sometimes lead to loss of analysis and data. Because of the way that the trusted research environment is set up in such a secure way, it's not got direct access to the internet. It's very hard to import scripts and things, or copy and paste, or to upload extensions to things like R or Python. Also, there is limited ability to upload things like Stata or SPSS, which we did persevere with. And although some of the analysis has been solely done on the trusted research environment and workbench, particularly with the Sudanese data because of the nature of the data sharing agreement, other bits of analysis we've taken off in accordance with the stipulations of the data sharing agreements and analysed within the University of Sheffield. So I think the main advantages of the workbench trusted research environment for us have been pooling and managing our data sets, especially across the kind of global team that we have. So we've been able to keep them in a secure place. There's not been sending data sets, by email or things like that. We've been able to upload them all to the trusted research environment and keep them there. And it's a central repository similar to like a shared drive that we'd normally routinely use in the University of Sheffield, but on an international scale. Due to the restrictions of the data sharing agreements, some of the analysis we've had to solely do on the trusted research environment, and that is very feasible, especially if you're a Python user or using applications which are already available. But there are, some issues with ease and practicality of analysis. And for us, some of the analysis we've done off the trusted research environment within the University of Sheffield, just because it's been easier for us. Thank you.
Brilliant. Thanks, Carl. Really insightful. Yeah, if you stop sharing, that would be good. Let me just pick up. That was really interesting, and thank you to you both for sharing very openly the pros and the cons here as we work with some of these emerging technologies. A set of resources that we've just put together with you, so we will share the presentation in a PDF afterwards. So a couple of things that you might want to look at in terms of more information on privacy enhancing technologies, trusted research environments, and some online courses on protecting privacy in practice. Some really interesting resources, if I could speak, in a rapidly moving area. And so with that, I'm gonna move us across into the Q&A. So Joseph and Carl, if you'd like to come back on camera, let's see what questions that we've got. Hopefully that will then result in not just people seeing me, but they'll see the three of us. The first question I'll answer, which is, can the slides be shared? Yes, Dorothy, absolutely. We will share a PDF copy of the PowerPoint. And also, as we said at the start, this session is being recorded, so the recording will be made available. So hopefully that is useful. The first question I can see is from Edel McNamara. In general, do you think there's a move towards the use of privacy enhancing technologies such as trusted research environments within research, as opposed to methods like sending data directly between individuals and institutions? So let me start with Carl, and then I'll pass to Joseph just for thoughts on that. So use of TREs as opposed to sending data directly between individuals and institutions. Carl, what are your thoughts?
I mean, I can only talk from the UK experience, but for things like NHS Digital, there definitely is this move. And I think the Welsh sales system is a trusted research environment, which is very well established, where people are given remote logins to do their analysis on NHS Digital, which is NHS data, as opposed to sending out chunks of data, which they then kind of lose control over. Because the data sharing agreements associated with them are very strict, it's very easy to accidentally breach the stipulations.
Yeah, makes complete sense. Joseph, what about you? Do you see a move towards this from your perspective?
Yeah, I agree. Because of the advantages that we see here, and thinking about the data security and all the data agreements that we sign, that this becomes a more secure environment to share and work with data. Thank you.
Yeah, thanks, Joseph. And I would concur with you both. You know, the International COVID-19 Data Alliance is convened by Health Data Research UK, who've been a very big proponent over recent years of the use of trusted research environments. And as Carl said, that usage is very widespread within the UK for health data research, and I think is getting a more global spread. And certainly, you know, we've been privileged to welcome all of the ICODA driver projects to trusted research environments as well. And as with any new technology, these things will iterate over time and will continue to improve. Next question, and again, I'll start with Carl and then pass to Joseph. What features do you think are missing in trusted research environments?
So I think the main issues are kind of ease of analysis. I've used, not just on this project, I've used various types of virtual machines and trusted research environments, and there is a kind of a spectrum of how easy it is to add applications that you want to use, access the internet in a way to download things which are useful, and how strict the trusted research environment is and how restricted it is in doing that. I think what was good with the trusted research environment provided by ICODA is some of those default tools which allow you to do simple analysis. I think if things develop and those tools get better, then it will hopefully reduce the need to ask permission to access, you know, another library or a browser or stuff to improve the ease of doing the kind of analysis that you want to do. Yeah,
makes sense. Joseph, what about from your perspective? Anything missing from trusted research environments, at least as you've experienced in this project?
Yeah, thanks, Neil. I think really similar thoughts. One is the tools that you'd like to use for our case was missing really most of the time, and therefore we had to try and bring this from outside the environment and get to use them there. And then secondly, I think the data analysis softwares, for example, this was really in R, and many of our team members were not able to use that initially, and we took quite a long, time to get everybody to speed. So availing more, data analysis software and data analysis tools would be much recommended. but also the space, the amount of space available to house all the data. I think that was kind of holding us back a bit, including a need to have a bigger bandwidth to be able to do what you want to do quite quickly. Yeah, so those are my thoughts really. Thank you.
Thanks, Joseph. Thanks, Carl. Brilliant. And I notice also in the Q&A, we have Owen with us from the Iridia Informatics team, who provide our trusted research environment. And he's indicated that both Carl and Joseph, he'd love to just have a quick session with both of you to run through some of the challenges and caveats that you face. If you're up for that, that would be great, and we'll continue to improve the offer here. Slightly different question, not to do directly with the trusted research environments, but we have a question from James Pickett on any overview of the public and patient involvement in the project. Very interested in Joseph's experience, or in Sudan in particular. So Joseph, can you give us a minute or two overview of public and patient and how they were involved in your project?
Yeah. Thank you, Neil, and thank you, James, for that question. Yes, our engagement was really more so with the providers, the service providers, and the Ministry of Health. So while we had the engagement workshops to review the data that we are going to use for the dashboard and to review the kind of things that they're interested in. Of course, one of the things they were expressing concerns over were the confidentiality of the data, and anybody coming within the precincts of the hospital being able to identify and see who is in the data. But I think they quite understood the confidence we had and the confidence we gave them of the secure environment in which this data was being processed, and also being able to use the summary data that we were getting out of the dashboard to help their daily work in making decisions about services. So in general, yes, there was quite a lot of interest and a lot of engagement with them, and they were quite concerned about that security, the patient data security and confidentiality issues. But at the end of it, they were quite happy to be able to use the data and the things that were developed out of the data, that's the dashboard, with confidence. I think that was a very good experience, and it informed our process all through to ensure that whatever we were leaving behind was acceptable to them, and they were excited about how it's going to help their service delivery experience in the hospital. I hope that helps. Thank you.
It does, Joseph. Thank you. And similarly to Carl, and anything that you would call out in terms of privacy considerations from within any of your stakeholder meetings?
Yes, so I think we only had sort of limited engagement for the PPI group in Sudan, but in South Africa, we've established quite a good PPI group, and we had a long-standing PPI group associated with the PRIEST tool in the UK. And data security is a concern for patient stakeholders, especially because of all the things kind of in the news which they hear. But when you generally explain to people that the data is anonymized, that it's for a good cause, and you can reference, that you've got a robust plan for data security, generally PPI stakeholders are happy with that. And that was something when we initially applied to ethics, we could go back to them and say that we consulted our PPI group and these are our thoughts about our data security plan, and that was quite helpful.
Thanks. And I guess the trusted research environment angle helped a little bit in that discussion.
Yeah, it did.
Yeah. Perfect. Good set of questions, and a thank you in the chat for Joseph from James. Any other questions from any of the audience? Okay, well, look, I think that was I'll wrap us up. That was a really great and interesting session. So thank you. Thank you to both Joseph and Carl for their fantastic presentations. Really exciting to hear the real use of trusted research environments. A huge thank you to all of our wonderful ICODA researchers right across the globe as they wrap out some fantastic projects. Big thank you to our technical partners, Iridia Informatics, who provide our trusted research environments, MMS Holding, who've done data curation for some of the projects, and the Sale Data Bank, who've provided storage and part of the federated analysis solution. Our funders, the Bill and Melinda Gates Foundation, Minderoo Foundation, and Microsoft AI for Health. Health Data Research UK, our convener, obviously my colleagues in the ICODA program. Without you, we wouldn't all be here. And thanks to all of you in the audience for taking the time to learn a little bit more in terms of trusted research environments and the experiences using them in what's a very exciting space as we look at privacy enhancing technologies going forward. Thank you all. Have a fantastic day. Thanks, Carl. Thanks, Joseph.